And Silvia?
The next case is presented by Dr. Emmanouil Androulakis, who is a post-CCT fellow at St. George's. Emmanuel, the stage is all yours.
Thank you so much, Silvia. Can you hear me okay?
Yes.
And can you see my presentation okay?
Yes.
Yep. Excellent. So it's a great pleasure and honor to be here amongst you all, the experts of sports and inherited cardiac condition. I hope you all enjoy this case as much as me. And I hope certainly I learn as much as possible from our experts today. I might just as an introduction, may I just say that deliberately, I think the polls are not particularly difficult, perhaps to Michael's disappointment. So I expect you to answer them correctly, but I would also prefer them to be as a trigger for further for further discussion about this case, which I personally found quite interesting for various reasons. But it's also a case that we commonly see in our practice nowadays. So with no further delay, this is a 70-year-old gentleman who is a veteran athlete. I would like to mention here that this patient is not local to us. So he lives up north, and the first set of investigations were done elsewhere. And he was referred to us for a second opinion. And obviously for that reasons, there has been some difficulty, as always in NHS, to retrieve images and recordings and so on. So this gentleman has got an impressive exercise history. He has been running since the age of 17 at the national level. He has completed many marathons in his time, achieving a personal best time of 2 hours and around 20 minutes. And at the time of presentation, obviously he exercised less, but he exercised 4 to 5 times a week, running up for approximately 40 to 45 minutes at a pace of 6 minutes per kilometer. There's no significant evidence of an underlying cardiomyopathy in the family or early death. And also, he's got 3 children in their 40s, all of whom are well, and they had not been investigated for a heart condition. He does not have any known risk factors for coronary artery disease. He's a normal blood pressure and lipid profile. And so incidentally, essentially, during the routine surgery assessment, an ECG was done and showed somewhat frequent ventricular ectopy of single morphology, and therefore he was referred to a cardiologist. So this is one of his first ECGs. Just a few comments here, if I may. So sinus rhythm at 58 beats a minute, normal axis, normal PR interval. I couldn't appreciate any significant slurring of the S wave in V1 or epsilon wave. There was some minor T wave inversion, I think, or biphasic T waves / flattening of the STs in V5, V6, but also inferior leads as well, which perhaps is probably difficult to appreciate on this ECG. Also, I think there was rather small voltages in limb leads and some fragmentation of the QRS, along with evidence of probably left atrial dilatation. About the ectopy, as we can see, there is obviously increased frequency, so 4 ectopic beats we can see here, which I think is of the same morphology. So left band branch block-like complexes with positive axis in inferior leads. I'm not sure if anybody would like to make any other comments about this ECG. Otherwise,
no, you did a pretty good job. Let's go.
Thank you, Mike. So just a bit of background as well. So we know from previous work that frequent ventricular ectopy may be associated with benign prognosis if an underlying disease as well as tachycardia-mediated dysfunction are excluded. And also ectopic foci located in the right or left ventricular outflow tract or the fascicles of the left band branch may give rise to actually quite frequent ventricular ectopy above that 10,000. That is actually usually associated and occur in the absence of any pathology. So from the work of Corrado, which Michael has summarized nicely here, we can also suggest that this left branch block with inferior axis may be considered as a likely benign or common morphology, which was associated with which has not been associated with heart condition in a large cohort. So with these thoughts in mind, shall we move on to the first poll, please? So essentially, what would your next investigation be? So reassure, given the absence of symptoms and athletic training. Would you do a 12-lead ECG Holter, or would you do an echocardiogram, a Holter monitoring, as long as a treadmill test?
Okay, let's see what the audience replies. In the meanwhile, I don't know if Jonathan has some thoughts.
Yeah, no, I agree with the 100% so far. You do have a fair amount of ectopy on that ECG. This is a 70-year-old masters athlete, so it would be inappropriate to utilize the international ECG criteria just by age. However, certainly the number of ectopics on that would not be considered normal. It does have, the transition looked to be on the earlier side. It looked like between V1, V2, so maybe an LV outflow tract type PVC perhaps, but you need to quantify the total number for a 24-hour period. Currently, just by having the number of ectopics present, imaging with an echo, and then of course, the treadmill to look for suppression of the ectopics. And again, I think given the age of this athlete, a veteran masters athlete, it's important to kind of have that overall ischemic risk stratification as part of that with the exercise test. So I would proceed with the gamut of those three initial tests.
Apparently, the audience. Yeah.
I'm sorry, just one other thing that I do think would be important in the history, and maybe this is more relevant in younger athletes that we see with a lot of ectopics, but a stimulant history as well, caffeine, energy beverages. And then an older gentleman like this, certainly coffee just is an important part that I would want to uncover during the initial history.
Okay, great. So the majority of the audience agree with you that the athlete should undergo full investigations like echocardiogram, 24-hour Holter ECG, and exercise stress testing.
So that's excellent. I think that's what we have all expected here. So thanks, Jonathan, for all your comments. Really appreciate it. Actually, having noted your comments about the international criteria as well, I'm just going to mention them briefly here. So obviously, the relationship, just to remind, the relationship between abnormal T-wave inversion and several forms of structural heart disease. Also, the frequency of the ventricular ectopy as well. Yeah, for all those reasons, is probably most reasonable to proceed with all those three tests. About the caffeine history, as far as I can recall from the notes, there's no evidence that he actually exceeds any normal limit or uses any other substances, etc. So moving to the first test, so this is the first echocardiogram that he had, was reported as having dilated RV with hypokinesis of the inferior aspect of the RV free wall, with some borderline longitudinal function, TAFSI of 17 millimeters. So the basal diameter was 5.3. The RVOT was 3.4. There was mild LV dilatation as well at 6 centimeters, normal wall thickness. It was noted also mild hypokinesis of the basal, inferior, and lateral walls. So there was also significant biatrial dilatation with no significant valve disease, and there was some rise of right-sided pressures at 45 to 50 millimeters of mercury. Essentially, the reporter was noted these findings and was wondering whether these are secondary to athleticism or an overlap between DCM and athleticism. However, it was noted also this regional wall motion abnormality in the left ventricle. So the exercise test was as follows. So he did 12 minutes and a half. Heart rate rose appropriately at 92%. It was mentioned that there was isolated ventricular ectopy which mostly suppressed during exercise. There was no evidence of no sustained VT or ischemic changes. Blood pressure rose appropriately. There was no symptoms or awareness of arrhythmia, and there was no V-runs or any other arrhythmia noted. Gemini was in recovery as well as the isolated ventricular ectopy. Unfortunately, we do not have the recording of this one. So obviously, Holter is a key test for evaluation the arrhythmic burden, as Jonathan pointed earlier. So this Holter was noted to have 19% burden of ventricular ectopy, predominantly unifocal. However, it was noted 2 runs, a short run of V, as well as a triplet, with no runs of atrial tachycardia or atrial fibrillation, and there was no symptoms reported. So for these reasons, actually, they proceed to do a 12-lead Holter, which I will show you later. So these are the first strips that we got, essentially. So I'm not sure if our expert panelists would like to make any comments, or I can make my own.
Sanjay, what do you make of all that ectopy for now?
Yeah, I mean, there's a high burden of extrasystoles. 19% is high, no doubt about it. And he has got this 6-beat run of non-sustained ventricular tachycardia on my left, and also got 2 different morphologies on my right. So clearly, this clearly warrants more investigation. I'd be very interested in seeing the 12-lead 24-hour tape just to see where most of these monomorphic extrasystoles are actually coming from. Whether they look like they're coming from the infundibulum, whether they're coming from the left or right, I can't be sure. Yeah. So,
but would you consider, I'm asking to both of you, a good sign the fact that they are mostly suppressed during exercise? Do you consider it a benign sign or not?
Generally, yes, I would agree with you that extrasystoles that suppress with exercise are usually benign. I normally find that these extrasystoles run between 100 beats to 140 beats per minute. So you get them on the uprise of exercise and you get them in the recovery, and they seem to suppress after about 140 beats per minute. I agree that they don't sound. I mean, I'd like to see the 12-lead 24-hour tape to see exactly. I mean, I don't think we've seen. I only saw that one 12-lead ECG, and I didn't see much more than that. I suspect they're all coming from the same focus.
Yeah, I would agree. I mean, that's certainly the dogma that we use. But I also agree, it is a high burden, and with these couple different runs, 2 different morphologies, I 100% agree that more investigation with a cardiac MRI is certainly in the cards, I suspect.
I think in general that if the ectopy increases with exercise, that's a concerning sign. If it reduces with it at peak exercise, I think we need to view it with a bit of caution. It may be benign, but on the other hand, we do have patients in cardiomyopathy that tend to do that, even with conditions such as arrhythmogenic cardiomyopathy.
I agree. We've got patients with recognized extensive scar that do that as well.
Good. Thank you.
May I just, it's just a genuine question of mine, actually. May I just draw your attention on the right side? Would you think there's an evidence of bidirectionality here?
I'm not going to read too much into it. I can definitely say there is definitely 2 different morphologies there.
Okay. Excellent. So move on to the 12-lead ECG. This was essentially the run that we were given as evidence of non-sustained VT. I'm not sure if in combination with the previous one, if you would like to make any comments, or I might just carry on.
No, I go back to what Jonathan said. It's difficult to know. I mean, the transition is at at V3, whether this is coming from the left or the right ventricular outflow tract, but it seems like it's coming from the infundibulum somewhere.
Yeah, absolutely. So I will move on then on the next slide, which essentially is what would be the most useful investigation. I think somebody mentioned it already. With all these thoughts in mind so far, would it be a signal average ECG? Would it be some further blood investigations to clarify things further? Would it be a cardiac MRI? Would evaluating coronary arteries also would be your next investigation?
So let's leave the audience some time to reply. In the meanwhile, I don't know, Jonathan, what do you perform?
Yeah,
first?
I think I was the one who mentioned the MRI. I mean, I think just based on everything we've discussed, I would proceed with the cardiac MRI.
What about a stress MRI?
I mean, I don't think that would be inappropriate for sure. I mean, for me, the bottom line is just further characterization of the myocardium. A stress CMR, in this case, wouldn't be my initial go-to. I think I would just order a standard resting CMR without contrast and proceed. What were you thinking, just in terms of further ischemic evaluation?
Yes.
Yeah,
to combine a morphological tissue evaluation with some inducible ischemia.
Yeah, I mean, particularly in this aged athlete, a 70-year-old male masters athlete, I don't think would be inappropriate. Certainly, we don't see as many of these 70-year-olds. I mean, we do see them, but not as common. So in this case, I think it would not be unreasonable.
Thank you. So the majority agrees with you, and they answered to go with the cardiac MRI.
Excellent, as expected then. So just to make some comments, obviously we know from previous studies, but also from this more recent study by the Italian group from 250 consecutive competitive athletes with apparently idiopathic ventricular arrhythmias, that left ventricular gadolinium enhancement was found in a significant proportion of athletes actually, and this was actually a subepicardial / mid-myocardial stria pattern, and so from the same group, this algorithm has been proposed for the evaluation of athletes with premature ventricular beats. In case one of the above mentioned tests is abnormal, additional tests may be needed based on clinical suspicion, i.e. a CMR to rule out a possibility of cardiomyopathy, obviously, as well as a coronary angiogram, which would be useful either way here. Perhaps the signal average ECG probably is not considered as a first-line investigation. However, this patient's history actually started a few years ago. So yeah. I note also that the authors here made a comment about genetic testing for CPVT, whether in case of a polymorphic exercise-induced ventricular ectopy is found. Moving to the next slide, which is the cardiac MRI report. So this showed mild biventricular dilatation with an RV to LV ratio of 1.2. An indexed volume of 113 with an ejection fraction of 53%, an indexed RV volume of 131 with an ejection fraction of 43%. And they have commented on the abnormal area of enhancement, which we will see just on the next slide, of the inferolateral wall, which was reported as having mainly subendocardial distribution, but with mixed features. And the reporter actually was plausibly wondering whether this is an episode of myocarditis or an embolic event. So these are our cine imaging. So just going to show this one as well as a transaxial stack here. If you can have a look, perhaps for regionality at the right ventricle, if you can appreciate some areas of dyskinesis or aneurysm. I'm not sure if anybody wants to make any comment, or I might just move on to the guard imaging.
So, well, for sure it's dilated, and the right ventricle looks a bit hypokinetic as well as the left.
Mm-hmm. Yeah, it's probably difficult to appreciate any regionality here. Obviously, it was just this transaxle stack. Unfortunately, we didn't have any further imaging or any other sequences that could appreciate the right side more.
There is a tiny bit of desynchrony, which I can see how it can become easily dyskinesis. But as Sylvia said, the main thing is that they look, well, all four chambers actually look dilated, and the atria look particularly dilated as well.
Yeah, that's a very good point, Mike. So the guard imaging here. So there was, as I said, it was reported as having mixed features, including subendocardial enhancement. However, perhaps it could be appreciated some areas of subendocardial as well. At portions, looks like almost full thickness. And I was also looking at these images and I was wondering whether there's any suspicion of mild enhancement in the basal septum. But also on the right side, I was wondering whether there's any evidence of enhancement, apart from obviously the tricuspid annulus, if there's any other evidence of enhancement in the right ventricle. Perhaps we can see that at the central image. And anybody wants to comment on this?
I would not be personally more concerned about the basal septum enhancement. You may see often as it may be an expression of overload pressure or of LAD. I'm more in doubt actually about the right ventricle, but I think I don't have enough, section to judge that.
Of course.
Yeah, I mean, the only area I'm convinced about is actually your lateral wall.
Yes.
It looks very subendocardial.
In the basal, subendocardial, and then transmural at the mid one. Yeah.
Yeah. So moving on, obviously based on that subendocardial area, which obviously everybody was suspicious of, we proceed to do some further investigations, including coronary angiogram, which did show ectatic vessels but unobstructed. Obviously, a signal ECG was done in the meantime, and actually all three indices were found to be outside of normal range. And also he was sent for a PET-CT, mainly for the exclusion of sarcoid, which didn't show any active areas of inflammation. But again, it was raised by a reporter a question of previous myocarditis. So at this point, we haven't established a clear diagnosis, obviously, and we have performed another set of tests, including a treadmill test and an echocardiogram. So this was a treadmill test which was done in our center. So the patient was exercised for 12 minutes, achieving 108% of maximal heart rate response. So frequent V's were noted this time throughout the recording, and there were additional morphologies noted, predominantly in the left bundle branch morphology as well as right bundle branch morphology with different axes. And there was evidence of bidirectional couplets as well, which did not develop to anything further. So this was at the first kind of minute. We can see frequent V. I think this is the morphology that we had identified earlier as well. and this is almost at the peak of his exercise. I think that we can appreciate various morphologies here, and I would really like to take the opportunity to ask your opinion about this as experts. If anybody wants to make any comments, or I can see what they can make out of this.
Jonathan?
I mean, yeah, I mean, obviously much more abnormal treadmill, you know, with the inducible ventricular ectopy. You know, you still have to wonder about atherosclerosis, you know, whatever type of, you know, could there be some element of underlying CAD? In addition with this, you know, I'm always hesitant to kind of throw out the genetic testing or to look for underlying inherited genetic arrhythmias, particularly in the setting of the abnormal imaging. Plus, this is a 70-year-old gentleman, and thinking of kind of the overall pretest probability for CPVT, it seems pretty unlikely. But I think that would be a consideration as well at this stage without a clear diagnosis.
Okay. Yeah.
Manu, we've got only a few minutes, so let's
okay.
move forward. Thanks.
Okay, of course. Yeah. Thanks for your comments, taking everything on board. Just briefly, I can see obviously there are both from the left bundle and the right bundle morphology with both inferior and superior axis. We can obviously infer that they may be coming from various areas actually. Just to move on, not to spend too much time, I would like to go to the next poll. Given our best evidence so far, what would you think this is the most likely diagnosis?
Well, that's a tricky question, I think, because yes, I mean, we well know that there is a kind of overlap between DCM and AC, so to say what is most likely may be difficult.
Where would you put your money, Sanjay?
It could be all it could be any of these three.
He gave us two easy ones and a difficult one.
Yeah, it could be any of those. I mean, clearly there is biventricular involvement. Little doubt about that. I mean, we haven't seen, you know, there's biventricular involvement. I've been thinking about this again and again. Certainly doesn't fulfill task force criteria for conventional task force criteria for ARVC. Obviously, with the Padua criteria and further modifications, there is certainly LV involvement plus a little bit of RV involvement. If I had to tick something, even though I think all three could be correct, I would go for number one, arrhythmogenic cardiomyopathy.
So would you genetic test, Sanjay?
I would do a genetic test. I'd be very interested, and you can shoot me down. I'd like to do an EP electroanatomical map here. That's what I'd like to do, just to see if there are low, you know, there are low voltages elsewhere in the RV that would convince me that this could be ARVC. But I think certainly would be a candidate who should have a genetic test for sure.
The majority went for arrhythmogenic cardiomyopathy, 55%, with a close second, the dilated cardiomyopathy at 30, and then myocarditis at 15. So I think we're a bit all over the place.
Yeah, and to be honest, that's very fair, obviously, and obviously, as Prof mentioned, I don't think we meet any criteria here so far, obviously. It could be probably easier to assume that from these three choices, perhaps the most plausible one is arrhythmogenic cardiomyopathy, but I don't think we still have got too much evidence on that one. So we just to try to complete the story, essentially, I'm just going to mention another echocardiogram which was done in our center. Just very briefly, obviously the left ventricle hasn't changed dimension, although the patient in the meantime was actually exercising less. And in terms of the left ventricle, still obviously we can see the regionality here. I think it moved forward. So nothing has changed from the left ventricle. From the right ventricle also, the dimensions are also it is a bit mild dilated. The longitudinal function is not terrible, as was not before, but it was noticed from our expert echocardiographer an area that was actually thought to be at the anterior portion of the RV wall that was not, perhaps Michael has alluded to that earlier. It was thought not to be moving so well, and it was thought to be hyperkinetic, if not akinetic. Perhaps the evidence is not very straightforward. I'm not sure if anybody wants to make any comment on that, but perhaps we could take that on board.
I think you need the eye of faith. Let's move it on.
Okay, excellent. So we did do gene testing. Actually, this was done from the other center, and it was the 11 gene panel was done, was chosen. This was actually negative, and it was various genes, including filamin, lamin, phospholamban, was included. And at this point, I don't think that a huge amount of evidence has changed, perhaps, but perhaps you can say with a certain kind of certainty if this person might have a borderline, if he meets criteria for borderline or definitive diagnosis of arrhythmogenic cardiomyopathy.
I mean, why couldn't this still be prior infarct? You have a subendocardial scar. Again, I understand his cath was normal, but just again, just thinking about other kind of potential underlying etiologies, prior embolic infarct. We already had a case like such as that, spasm. Something in the past. Could that still be on the differential?
I guess it can be. And I think at this point, perhaps it's relevant to mention the most recent card MRI, which was done by an expert imaging person elsewhere. Unfortunately, we haven't got the images, but it was reported essentially as having in the right ventricle, there was reported a bulge of in the RVOT area with dyskinesis in the moderator, at the area of moderator band, and there was evidence of fat at the right ventricular level, and so there was a suspicion that this has been progressed compared to the previous MRI, and there was evidence of some enhancement in the RV free wall, but also fat which infiltrated the mid to apical portion of the RV wall. So with this, and obviously the LV GAD hadn't changed or hadn't been reported in a different manner. So with this evidence, overall, it was thought that we have probably some evidence from both sides, but perhaps we can reach a borderline of arrhythmogenic cardiomyopathy here. Having seen the morphologies of the non-sustained VTs as well, but also the morphologies on the most recent treadmill test. If anybody else wants to make any comments on that?
Manu, we need to close in 30 seconds.
Okay, so moving on to the fourth poll here. So what would your recommendation be in terms of exercise?
So we ask our experts because we really need to close. So Sanjay, what would you do?
Well, if my working diagnosis is arrhythmogenic cardiomyopathy, I know we're gene elusive here. I would have to ask him to reduce the intensity and volume of exercise. So number 2 would be my best answer.
Jonathan?
Yeah, and then again with this additional repeat MRI, if there's now architectural deformation in the RV, I agree. I think you got to go with 2.
Cool. Manu, was that the right answer?
I guess so. And obviously, we know the evidence about the exercise and an arrhythmogenic phenotype, so I'm not going to say too much about this. Just for the sake of time, I'm just going to make, and obviously, just to note that this is also for gene-positive, phen-negative athletes. And just some learning points in the end, if I may. So obviously, sometimes there might be borderline or suggestive evidence of or suggestive of other pathologies. And obviously, contribution of exercise may be a challenge. Perhaps we may go with the best evidence we have. Obviously, I'd like to mention the imaging modalities here. The important role, and also CMR is the gold standard, but gives information, I think, in my opinion, at various levels. So we have to be suspicious and look for specific features, even with various sequences such as mapping, fat, SAT imaging, etc. Particularly in our case, and we have to have a high level of suspicion. And also, follow-up is important to monitor subtle abnormality, which may progress to confirm or challenge our previous findings. Thank you all for your attention.
Thanks, Manos. I think that's a very important message to leave people, that sometimes we need time to make a diagnosis. And the other point, obviously, is that the older the individual and the athlete is, then the more challenging may become, because there may be more than one underlying pathologies or evidence. So from myself, I would like to thank Manos, Raghav and Saran for the wonderful presentations, Jonathan and Sanjay for their expert opinions, Sylvia for co-chairing this session with me. And because we're running a bit late, I'll pass the microphone to Gerardo Finocchiaro, who will do the imaging quiz for us with his expert panel. Gerardo, the microphone is yours. Thank you very much.